Good evening. Can you please all switch your phones to silent? There is a £20 compulsory donation to charity if anybody's phone goes off this evening. So if you could do that, that would be great. My name is Ben Page. I'm the Chief Executive of Ipsos MORI, and I'm simply here this evening to keep our eminent panel to time and then help facilitate some questions and discussion, which I know several of them are very keen to launch into. Their biographies are all in the pack. I can promise you some PowerPoint. This is Ipsos, MORI and Kings, of course, so there will be PowerPoint. It won't be too long and it won't be too painful, but there are some interesting new findings. And then we have some of the key players from public health in England, both on the stage and in the audience. I'm sure we'll have an interesting discussion which is incredibly topical and will be important to all of our lives, whatever happens. So without any further ado, I'd like to welcome to the stage Louise Park. Louise is my colleague who leads our work looking at public health and the NHS. And she's going to talk about where the public might be in terms of how interventionist or otherwise government and local government might, should, or could be. Louise, the floor is yours.
Thank you very much. As Ben said, I promised to make this not as painful. So I look after the public health work that we do here at Ipsos MORI. I've got the pleasure of taking you through some of the data that we have on this debate. It is a debate that sort of comes up time and time again, really, and is talked and framed very much in terms of morality. So on one side, we've got people saying we shouldn't intervene in individuals' own liberties, their own choice. And on the other side, we have people arguing that actually there's a moral obligation for governments to intervene to try and deal with some of the inequalities in health that we see that exists and to try and help shape our environment to be more health conducive. So I'm going to kick off by telling you what the public think about this debate. Really, the public are very split. So here you'll see we've got 39% agreeing it's the government's responsibility to influence people's behaviour to encourage healthy lifestyles. But equally, you've got 32% saying, well, you know what, the government just shouldn't intervene in this matter. So very split. What does that actually mean? In terms of giving you an international context, here you can see you've got countries right at the top very much in support of government intervention. So here, 52% saying it's the government's responsibility to influence people's behaviour, all the way down to 12%. I promised a bit of audience participation, so I'm interested to know if anyone can guess which country sits right at top with 52% saying it's the government's responsibility. I don't think I heard it. It's actually Russia. And what about...
Strong government.
Strong government. Okay. What about down the bottom, 12%? Well done. It's like you've seen my slides. So yeah, America really not very supportive in terms of government having a role in influencing people's behaviour. Other countries then, you'll see that we sit sort of between Germany and Poland. Again, they're countries where the public are quite divided on this issue. So, if we know that 39% think government has a responsibility to intervene, we also ask the public, what about local councils? Because obviously a local council now has a huge responsibility in terms of public health. It's the last bit of audience participation, but I am interested to know if you think the figure for local councils would be higher, lower, or about the same. You're also split, but actually it's 36, so very much in line, suggesting that really the delivery arm of public health, be it national government or local council, at this stage doesn't appear to have a big impact in how the public perceive it. It would be interesting to know if the public were aware of local councils' responsibilities in relation to public health and how that might affect this figure here. So that gives you a broad overview of where the public sit. I'm going to take the stance that actually both sides of the argument are really important. So we need the public to own public health and take responsibility for their health. We also need the government to help individuals make those choices. So the presentation is going to be split in two. And the first half is going to look at how can we get the public to own public health. So, kicking off then, we asked the public what do they see as the biggest threats to the health of the British population. Here you'll see obesity coming up really strongly, 54% of individuals mentioning that, alcohol, poor diet, smoking. The public are really actually quite spot on in terms of naming some of those big lifestyle threats to health. For example, we know that about 20% of us are drinking regularly over our recommended guidelines. We know that only a quarter of us are having our 5 a day. We know that 35% of us aren't doing the right, are meeting exercise guidelines. So the public are picking up on these and are able to name some of those key threats. But the pattern changes hugely when we ask them what do they see as threats to their own health. So just skimming across it, you can see the profile and the shape of that chart hugely different. I think this brings up two sort of important points. One is, are we dealing with a big issue in terms of misperceptions? So, for example, right up top, we know that 2/3 of the population are overweight, but here we've only got 19% saying that they see obesity or overeating as a threat to themselves. So is that a challenge going forward? How can we convince individuals of the risk that is present to themselves? The other thing that this chart screams out to me is, in blue, you see the key threats being listed as lack of exercise by 38%, stress by 36%. So with stress, we know that that feeds into lots of the other behaviours, so alcohol consumption, what we eat, how much exercise we do. So does this point to the need for us to communicate to the public in ways that is relevant and meaningful to them? And if they're saying, you know, stress is something that is affecting me, is that what we should be tapping into? This slide really emphasising that misperceptions point about how people see themselves as reality. So in this sample, we had 59% who were classified as overweight, 40% said that they were overweight, and 22% said they were unhealthy. So this is really hammering home that point that the Chief Medical Officer was talking about last week, which is, are we at risk of normalising obesity and overweightness? And is that something that we really need to be challenging? Not all glum news. We do have 2/3 of the population agreeing that they themselves need to live a healthier lifestyle. 85% of other people, they need to lead a healthier lifestyle. So there is some claimed desire to improve life, or lifestyle, sorry. So I guess we can think about what drivers of change can we lever and use. So this is data from individuals who've made a long-term or a change to their long-term health, and then we ask them why. So two predominant reasons came up front. So quality of life and appearances, the drive to look better was really important, far more so than some of the other factors listed. So impact of my health and my family, concern about not living as long as possible, doctor's advice, rating much more, sort of less strongly than those two top factors. So important consideration in terms of how we can try and leverage that desire for people to improve their lifestyle. Can we be communicating to them in terms of quality of life and appearances? Another thing to consider in terms of the public health messaging then is who should be messaging to the public. So this shows trust in various professions. You'll see trust in doctors high and as always being high, much higher than trust levels seen for civil servants and politicians. The point I'm trying to make here really is, well, that while this is sort of unconditional, we're just asking people trust in professions. So we don't have data that says trust in professions to tell us about our lifestyle. But the point I'm making is that we trust different professions very, very differently, and that's important in terms of who delivers our public health messages. We did see on the slide earlier that perhaps doctors' advice isn't that important in changing people's behaviour. But it may well be that people aren't going to the doctor for lifestyle advice, or it may be when they do, they're not getting lifestyle advice. So the point really is messenger very important. So that's stuff to do with the public side of things. This next bit looks at how can we increase public acceptance of government intervention. recognising that acceptance of interventions is not the be-all and end-all, and there are examples of unpopular interventions that have been very effective. So, for example, the introduction of seat belts as a legal requirement. So it's not the be-all and end-all, but it is important. It's important because a nanny state isn't always going to be conducive to people doing what you want them to do. Sometimes people may sort of act in the opposite direction simply because it's sort of a jerk reaction to it. It's also important because if you've got some sort of public health initiative, like a smoking cessation, you want to see uptake of that scheme, then obviously acceptance of that intervention is important. Equally, creating sort of norms within societies is important. So, you know, if, for example, it becomes more of a prevalent and accepted behaviour to go and have your sexual health screened, then public acceptance of these kind of public health interventions is important. So that's where I come from on this. The first thing I want to show you is some data about smoking. So we asked individuals and we showed them different sort of strength interventions, if you like, and asked them to what extent they'd support them in order to encourage people not to smoke. So you'll see, working top downwards, we have the softer interventions, if you like, so the provision of information, almost universal support for that, 92% saying that they'd support that. Then we had incentives, so here an example was given of a financial incentive, so people be given money or vouchers to stop smoking. Disincentive, so here the example we used was actually the ban of smoking in public places, and a complete ban of smoking here supported by 45%. So the pattern really is quite obvious, and we see it in other behaviours, so to do with saving for pensions, to do with how people act in terms of environment and recycling, that the softer interventions tend to be the more accepted interventions. But it's important to consider the behaviour in question. Levels of acceptance differ accordingly. So here we've got some data on vaccinations. Again, you'll see a similar pattern. So almost universal support for the provision of information about the need to get a vaccine, all the way down to the more intrusive form of interventions, here suggesting that a law is put in place to make vaccines obligatory. Where the differences appear in terms of these two behaviours that we're looking at is in terms of incentives and disincentives. So the point really being is that acceptability depends hugely on the behaviour in question. It depends also if that person themselves exhibits the behaviour. So, you know, a smoker would respond very differently to this set of questions compared to a non-smoker. Always worth bearing in mind that the public are very happy to contradict themselves. So here we've got 45% agreeing that government should ban smoking altogether, but 41%, the same group of individuals, saying that government should not get involved in how people make decisions about smoking. So you'll see that 1 in 4 actually hold both of those seemingly completely contradictory views. Always worth bearing in mind. I think that's probably why policymakers are quite tentative in this area, because understandably so, the public can give mixed messages. Again, this may reflect things such as it's okay to stop that person's bad behaviour over there, but just don't impinge on my liberties. Or it may be, you know, in principle, I don't like the idea of a nanny state, but actually, you know, if you improve my environment, I'm in support of that. So worth bearing that in mind. Also worth thinking about acceptability towards an intervention is not static, so it shifts over time. A good example would be the introduction of the smoking ban back in 2007. You tend to see low levels of acceptability right at the start, where it's a new idea, no justification has been put forward for it. That builds as more details become apparent and support grows to the point where there's sufficient support for an intervention to go ahead. What then you typically tend to see is that support levels sort of drop off as more and more details emerge till we get to this lull where there's a panic before implementation. And then we see acceptability levels start to rise again. So, for example, now you see support of the smoking ban. We've got 74% of individuals in support of that, and that has climbed since it was introduced. People realise that there are benefits to it. It's not as awful as they might have feared, or they might believe that there's no point in fighting the cause, you know, it's being introduced now, and so levels of acceptability increase. So it's worth bearing in mind that when you measure acceptability, you might actually just be measuring where you are on that cycle. I haven't actually touched upon nudges, so in terms of the scale of intervention, the force, I talked about the provision of information and then the use of incentives, but nestling in between those two is actually a whole plethora of nudge-style options. So we gave respondents a whole different series of examples, and actually support for these more nudge-type interventions are quite high. So for example, we've got 83% saying that they would support food producers reducing the amount of salt and sugar put into food, which is good news for the responsibility deal. We've got 76% in support of supermarkets removing confectionery from checkouts, as Lidl led the way in January. We've got 73% supporting the cafes and restaurants printing information on calories on menus, although I have seen some research to suggest that this happened in New York but didn't seem to have a big impact in terms of behaviour and menu choices made. We've got public money from taxes, so 71% supporting public money from taxes being used to provide free fruit in schools. An interesting finding, particularly given that there was a report released today in the media about 5 a day is not enough, it's 7 a day. So what role does government have in terms of helping individuals get access to fruit and vegetables? And 70% here giving support for TV ads for junk food not being shown before the 9 p.m. watershed. So really quite high support for some of those interventions. Where support levels drop off are the bottom two, which have direct impacts on individuals' purses. So here we've got supermarkets should not offer deals on sweets and chocolate, 49% in support of that, and 49% in support of cafes and restaurants adding salad or vegetables as a standard side dish, even if it did increase costs. The last thing I want to touch upon before handing over is the effect of how we frame some of the public health messages that go out. So, for example, if you were to think about toothpaste advertising or something similar like that, you could see an advert with shiny, healthy, happy gums and teeth. You could see an advert with really horrible, gnarly gums, and the effect would be very different. It would make you feel very differently about it, although the end goal is to get you to buy toothpaste. The same principle here is that we wanted to test how individuals felt about government involvement in what people choose to eat, depending on how we'd framed it to them. So we had 4 groups of individuals, and we had 4 different types of message frames. So we talked to some individuals about a government norm, and we said, listen, other governments around the world are intervening in healthy eating. We talked to some people about the protection of children, so we talked about high levels of obesity amongst children and the need for government to protect children and help families do so. We talked about protection from industry, so junk food manufacturers using advertising and marketing tools that are really quite advanced, and government's role in protecting the public from that. And some individuals saw some facts about obesity and the cost of obesity to the NHS. So then we asked people to what extent they supported the government should not get involved in what people choose to eat. And it was startlingly similar across all 4 of those groups. So it appeared at that stage that messaging and how you frame an intervention didn't really have an effect on how people responded towards it. But for some of the softer interventions, so things like the provision of information, the use of incentive schemes, so here talking about paying people or giving them vouchers if they achieve a certain target weight, that actually saw a pattern starting to emerge in the data, so that people who saw the government norm were tending to be more supportive of that as an intervention than the least effective here was talking to people about the facts to do with obesity and the facts to do with the cost to the NHS. So quite interesting there in terms of how the message is framed. So just to sum up from me, we're very evenly split in terms of government intervention, and that doesn't really change when we look at local council intervention. It will be interesting to see with time as people grow in terms of their awareness that public health responsibilities sit within local government. Should we be talking about stress and not obesity? So using people's frame of reference, what matters to them, what has meaning to them, to try and encourage them to change their behaviour. Public acceptability for interventions, that declines as the force of that intervention increases. But we know that acceptability is just one factor. So it's important, does the public recognise the scale of the problem, and do they believe that the intervention that you're proposing is going to be effective? In terms of nudge interventions, they're actually fairly welcome, but as long as they don't cost directly to the individual. And clearly there's some misperceptions out there about self and reality, and those need to be challenged. But given what I've just presented about message framing, we've got to recognise that there may be limitations to talking just in terms of facts only, and actually it may be more successful to talk emotively. And that's it from me. So I'll be very interested to hear what the panel have to say in response to that, and also any questions later. Thank you very much.
And just if you love slides, they will be on SlideShare or our website, or the King's website, so you don't need to worry about that. If you love Twitter, as I do, then you can use the hashtag Kings Ipsos MORI to tweet along. But I'd now like to ask Duncan Selbie, who's Chief Executive of Public Health England, long career in the NHS and public health. Duncan's going to say a few words. How does it look to you, Duncan?
Good morning, everyone.
Evening. Yeah.
Fabulous start. Good evening, everyone. Thank you, Louise. I think I want to emphasise that we should follow the evidence. We should listen hard. This is an incredibly powerful contribution to our thinking about what we do over the next number of years. What Louise touched on at the end about facts versus emotion. Can I concentrate on emotion for a moment, and then maybe we might come back to the facts. So we've had 6 decades of universal access to an NHS, free at the point of use. We've had a huge investment of new money in the past decade. It's gone into the NHS, yet we still have the inequalities today that existed 40 years ago, and in some instances they're widening. And your life chances, expectancy of life around the nation can be as different as 15 years, typically 10 years, but very commonly as well 7 years, just from one end of a town to the other. And what the academics and researchers in places like King's would talk about are the socioeconomic factors. They talk about the behavioural contributions. They would talk about the environment. They may talk about the genetic contribution, your start in life. But what more ordinary people might talk about is the importance of economic prosperity, about whether you have a job or not, and how important that is for your health and the choices that you have. The importance that brings for children, and about radiating benefit and aspiration. They'd go on to talk about the importance of having a roof over your head and about somewhere to live. I'm not talking here about people that are in the criminal justice system or with a severe mental illness or are homeless, but just ordinary citizens, and the importance of not being isolated in your life, in the elderly, but throughout life as well. And the contribution of health care in this context is placed partly to the fundamental error we all make. It's entirely understandable in the public's mind, because we all make this error of conflating good health with health care. I think because we're British, we'll argue that it contributes about 20%. The Californians have just published their analysis of the contribution of healthcare at 10%, but nobody's arguing it's a huge contribution. So I want to begin by talking about some of these inequalities that have been around forever have to be amenable to intervention. And this sort of evidence is incredibly powerful. It takes us into a whole new understanding about the balance between individual responsibility and what can government and what can policy contribute. Context is everything. So what we have is a responsibility to address inequalities. It's been given to me to protect and improve the public's health. That's the mission for Public Health England, to work with clinical commissioning groups, GPs and others, a legal duty to address inequalities, for the first time given to a health body. So what is it that we can do to make the biggest difference? As Louise said, in ways that reach people in relevant and meaningful ways. What should we do? and this evening is a great opportunity to explore this. We know that if you're at the wrong end of this on income, if you're lucky enough to have a job, but at the wrong end, you're twice as likely to smoke as at the professional end. If you're a smoker, your children are 3 times more likely to smoke. If you're at the wrong end, you're not going to be, whether it's 5 a day or 7 a day or 10 a day, they're not getting 1 a day or 2 a day. So we need to be cognizant of the context in which people are living their lives. And whereas we might have thought that actually it was a good intervention to say, you know, smoking's not good for your health, but we were missing the point that whoever we were having this conversation with was concerned about whether they could pay their rent, afford their heating, worried about going out the front door because of a community safety concern, and the intervention is Sir Nigel popping in and saying, you know, smoking's not good for your health. Your next visit is to the local A&E to have some bones repaired. So I think the answer to the question needs to be that it's both individual responsibility and it's government intervention. And we've got this evidence from MORI, but from others, about actually people are quite willing to go with sensible things, but it's really about information, it's about communicating, and it's about incentives. There are other things we might do. We know that there are interventions that are definitely evidenced that would make a difference, like minimum unit pricing for alcohol. We know that would make a huge difference. But mostly it's about how we get information and knowledge to people in ways that are relevant and meaningful to them. I think you'll be aware of the impact of smart technology, that over 90% of the adult population have access to mobile technology, 75% of smartphones. Not everyone can afford the internet access all of the time, so we need to be sensible about this, both those that don't have the money, but also the elderly. We today are in touch with 6 million people digitally through our work on Stoptober. Are you familiar with this? Change for Life, some of our sexual health programs. I see the future as a sort of a three-way, some balance that we need to strike between the behavioural sciences, about what works in relevant and contextual ways, the digital possibilities. I don't have this image, but if you look today just how many people are using technology just on a train carriage, and you compare it with 10 years ago, it is just, you maybe had one phone 10 years ago and now everybody's doing it. And then the third is personalisation. How do you make this personal? And I'm convinced that we get into this sphere, we get beyond believing that the answer is more money into state services, that the answer is about more money into healthcare, and that we do all that we can as a nation to get economic prosperity. That if it was Clinton, it's jobs, stupid, can we get jobs, and well-being in this context is that local people are benefiting as the greatest contribution to improving health. So I look forward to being interrogated in the Q&A.
So we go from the centralising bureaucrat at Public Health England, one of my good clients. This is what we're like to the clients. Imagine what we're like to the enemies. To Janet Atherton, who is actually at the coalface, representing the Directors of Public Health, but also long experience herself as a practitioner in this area with plenty of hard-won experience. Janet, how does it look out on the ground to you?
It's really interesting actually listening to some of the presentation which Louise gave. So as Ben says, I'm coming from a perspective of a Director of Public Health working in a borough in Merseyside with its share of deprivation and also some very affluent areas, and having moved over from the NHS into the council a year ago today. Yeah. Indeed, a year ago today.
Congratulations, Public Health England.
Well, Janet.
Yeah, indeed. Yeah. Yep. So we've survived that first year, and it has absolutely flown by. But that initial question about is it seen as being a responsibility of local government to influence people's lifestyles? I was actually quite encouraged by that percentage, to be honest, because I'm sure I've seen previously surveys where they looked at the role of the health service in terms of improving lifestyles when public health sat within the health service. And it was a very, very depressingly small number of people who saw it as an issue for the health service to actually tackle. So that for me was quite encouraging, and also the fact that it was very similar to national government. And I guess one of the questions there is, what do people think of when they're thinking about influencing lifestyles? Because I think in terms of the work that I do with the local authority, and things like influencing the way that schools operate, the way that green space is provided in the borough, library services, leisure services, planning, transport, housing, all those things impact on people's health. They're all responsibilities of the council. And yet, would people be thinking of that when they're asked that specific question about lifestyle? Or would they think about the services that we commission, which often actually sit within the NHS or with local charitable organisations like our Stop Smoking services, weight management, those more traditional kind of lifestyle services. So I guess in some ways, some of what local government does through commissioning may well be perceived as actually being delivered by somebody else that they don't associate really with the council. And certainly, NHS health checks is something which a lot of people will be receiving. It's got the NHS badge on it, but actually it is commissioned by local government. So, there's issues there. The information about what people understood about the threats to their health was also very interesting, because obviously there was that kind of clear understanding about the issues. But for me, there was also something else in there, which is the things which come out very strongly about the things which affect everybody. So everybody has to eat. Everybody has mental health in some way, shape or form, whether they're stressed or whatever. And everybody is, in some sense, needs to be physically active. But not everybody in the population currently smokes, so it's a minority of the population who smoke now. So it's not surprising that many people are saying that smoking isn't a big influence on their health. So that needs to be taken into account in the interpretation. And then some of those other things are things which are a consequence of those lifestyles. So things like getting cancer, diabetes, and that's another step removed from the initial action that somebody takes. So that getting ownership of things like cancer and diabetes as being related to something that you take, the choice that you make today about what you eat for your supper, whatever, that it's a bit too far distance, and often it's not going to happen to me. The information about obesity, drinking, the social norms, I think that thing about social norms is really, really important if we're trying to get into any of this. And certainly some of the work that I've done around tobacco control over the course of my career has been about how do you shift those social norms. That kind of the curve of acceptability is really, really important if you're trying to build up public support, because national governments or local governments will not put things into place that they do not believe have public support. There is that issue about government by consent is really, really critical to actually making progress on these issues. So, sometimes we think we need to be lobbying politicians about things, but actually sometimes we need to be thinking, what do we do to shift public views on this, which will then, in its turn, put pressure on politicians to change as well. So for me, that acceptability curve needs to be thought about, not just in terms of the public, but also politicians, but also professionals, and about how, we've got very different views at different stages as evidence starts to come about. Different professional groups may sometimes argue about different things in terms of what would be most effective interventions, that kind of thing. The other thing which really struck me about that acceptability curve is we've looked really at what's the role of government and what's the role of the public in this. But this is a very complex system, isn't it? We're not talking really about an either or an or. I would think, for instance, if we're looking at the moment around the issue around standardised packs, for instance, which is being reconsidered by government, as we speak, the issues there about how industry influences and gets stories in the media, which then the last minute panic thing, I think is a real issue, isn't it? You know, it's there again around, you know, the way that the food industry operates influences hugely the way that people's lifestyles. You know, supermarkets, huge influence on the way that we think and act. And lastly, I just wanted to say a little bit about the message framing issue, because I think I was struck by the, you know, using, actually for people who are anti-government involvement, it really made very little difference how you frame those messages. But it does make a big difference for the people who are, you know, interested, may want to change. And quite often I think, certainly it certainly made me think in public health terms. Quite often, if you think about public health reports, are often framed in statistical evidence. It costs the NHS this much, it costs society this much, and therefore it's, you know, it's an absolute fact that we should do something about this. And a lot of that is driven by having to make very hard business cases. You know, when are you going to get the return on investment from a particular approach? But I think you need different messages for different audiences, and certainly that would the issues about bringing in international experience. If they can do it, why can't we? Protection of children, all those things have been really, really important all the way through the different interventions around smoke-free, whether that's smoke-free legislation, increasing the age of sale, point of sale displays, and now looking at plain packaging. All of those things have all played into all those, the more emotive arguments have actually probably been more useful and more influential than some of the hard facts.
So we're getting this theme around emotion versus rationality. I'd now like to welcome our partners at King's to respond. Dr. James Rubin is a senior lecturer in the psychology of emerging health risks here, and I'm very pleased that he told me while we were having a cup of coffee before this that my mobile phone wasn't going to kill me immediately, so I was quite pleased about this. Is there anything else you can say that will cheer us up, James?
The emphasis was on immediately there.
Right,
we'll wait and see.
Right, okay.
I come at this from the perspective of an academic psychologist. I particularly work in the field of health protection, looking at how people react when large bad things happen, when swine flu broke out, or when the London bombs went off, or when the polonium-210 incident happened. And I think I'd like to spend my 10 minutes, if I may, talking a little bit about how what Louise has presented translates into that field, where we have to get members of the public very rapidly to adapt their behaviours and engage in protective behaviours that we hope will do them some good and protect them from harm. And also looking particularly about an issue of differentiating between groups of the public, because the data Louise has presented is very much at an aggregate level. What do the public think? And it's important to recognise there are subgroups within that, and we need to take consideration of those subgroups because they can be quite important. First of all, the issue of do we need this kind of evidence to help with the interventions we produce in the context of a public health crisis? We certainly do. In all sorts of instances, we urge the public to take protective behaviour and are disappointed by the numbers who do so. I can give you examples, many examples of this. During the anthrax attacks in the US, about 10,000 postal workers were potentially exposed to anthrax and were asked to take antibiotics as a precautionary measure. Now, uptake rates for those antibiotics varied from sorting office to sorting office, but the overall rate was about 40%. In some sorting offices, it was as low as 20%. So people potentially exposed to anthrax, 80% of them wouldn't take the pills. Similar kind of thing applies in the UK. At the very start of the swine flu outbreak, when it was still very much an issue in Mexico, and all the information coming from Mexico was this was a very bad outbreak that was heading our way. You'll remember, we were awash with newspaper reports. Department of Health was pushing out lots of advertising, advising us on what to do to delay the spread of flu. Simple steps, washing your hands, sneezing into a tissue, making plans with your neighbour about what to do if one of you became ill. And we did some research looking at what the uptake of those behaviours was, and it was around 35%. 65% of people were doing absolutely nothing in the context of a pandemic heading our way. So there's certainly plenty of scope for us to develop innovative behavioural science interventions to try and increase those rates. And many of the things suggested by Louise, and they're incorporated into that presentation, apply directly across to my field of work. So, for example, tackling misperceptions and providing information. Those are certainly things that we know are very important and that can be influential. Many members of the public have very low baseline levels of knowledge about the kind of hazards that I deal with in my work. And I include myself as a member of the public there. So chemical hazards, radiological hazards, biological hazards, what are these things? What do they do to us? I think about one participant from one focus group I did, and we explained to her if there was a dirty bomb that went off, you might be advised to have a shower. And she said, well, I might do that, but I probably wouldn't, because when radiation goes up, it's like smoke, isn't it? And you inhale the smoke, and that's what harms you. So what good will a shower do? And she hadn't realized we were concerned about radioactive dust that might be on her skin, and the issue was washing that off. So without these kind of baseline levels of knowledge and improving knowledge and tackling misperceptions, many of the behavioural interventions we might seek to do are a non-starter, really. And lots of the other things Louise talked about, so again, I think apply directly across. Things like looking for the drivers people have to protect themselves or protect their family, and the barriers that people face in engaging in these behaviours and tackling those kind of things. There are other situations, though, where the kind of interventions, the kind of behavioural interventions we might want to encourage become more complex and become acceptable to some groups but unacceptable to others. And I'll give you an example. In the SARS outbreak in 2003 in Singapore, the Singapore government decided to quarantine people who may have come into contact with someone infected with SARS. Now, this intervention wasn't to protect the people who were being quarantined, it was to protect the wider public. And it was very much a stick approach rather than a carrot approach. So a private security company was employed to install CCTV into the houses of people who were quarantined. People were phoned at random times during the day to check they were still in the house. If they weren't, there was a fine of $4,000 or imprisonment if you hadn't complied with this. Now, rates of compliance were very high. And acceptability among the general public was very broad. But it was a risky strategy, and it's risky because you risk having a conflict with that subgroup who you're asking to accept the intervention on behalf of the wider public. They're not benefiting themselves from doing this, but you're still asking them to change their behaviour. In this country, we might look at healthcare workers. Healthcare workers are recommended to have the flu vaccine. Now, I won't embarrass any clinicians in the audience by asking you to raise your hands if you've had the vaccine or not, but I can tell you at a group level, it's depressingly low. During the swine flu outbreak, about 40% of healthcare workers had the swine flu vaccine, and it's around about 25–30% of other workers who had the seasonal flu vaccine. Now, again, in this situation, we're asking the healthcare workers to have the vaccine not to protect themselves, but to protect the public. And it was interesting, Louise's data saying 41% of the public think that seasonal flu or pandemic flu vaccine should be mandatory across the general public. Had we asked them, or had Louise asked them, what do you think about healthcare workers who want to work in the NHS? Should it be mandatory for them? I suspect the number would have been far higher. But again, we're balancing what's acceptable for the public versus what's acceptable for the healthcare workers. And it's where those conflicts exist that I think we have a complexity to deal with. And I want to finish with one last subgroup, because there are cultural differences within the UK as to what is acceptable in terms of the kind of official interventions that we face. And there's one subgroup that are very au fait with nudge techniques and shove techniques, and that's the military, where the concept of voluntarily having a vaccine is something that's slightly alien. There's always been a tradition of implicit consent or implied consent. So much so that in 2003, when the military decided for one particular vaccine to take a slightly different approach, this is the anthrax vaccine, and to have much more in the way of information provided to soldiers and a written consent form, an official cooling off period, uptake for that vaccine went down. And when we asked the soldiers, why are you not having the vaccine? Their response was, well, because it's voluntary, isn't it? There must be something wrong with it. So I applaud very much the data from Ipsos. I think understanding what interventions are acceptable to the public is really crucial if we're going to drive this debate forward and understand what we can do, what we can't do, and how we should alter our interventions. But we need to be careful. It's not just a case of the public. There are several publics and several levels of acceptability, and it's balancing those acceptabilities that I think is the complexity, and it's why I'm grateful I'm not a policymaker and just a researcher. Thank you.
Okay, now we now have half an hour or so before we provide you a very healthy treats and snacks downstairs to quiz the panel. So to start, I've got some questions if none of you have, but I imagine some of you will. So any questions for Janet or Louise, Duncan or James? Right, okay, so we have one here and then I'll work my way back. Okay, and one there. Right, and I'll come to you in a second. Michael, do you want to go for... Can you tell us who you are and what your question is, please? We'll do three at once so that we can have plenty of... Yeah.
I'm Maria Serrano. I work at Imperial in clinical research. It's not a question as such, but just a comment and observation, especially to Dr. Rubin. It's always made me... well, at first I thought it was ridiculous, and then it made me really angry how we as a society are losing our common sense, and how things that made us laugh a few years ago, like carefully may contain nuts kind of example, we are seeing them as more and more common. And one reaction I personally had, and that made me really disturbed this Saturday, was like I was walking along the river, and suddenly I saw a barrier that was too low, and there was a danger of falling over. Now, before, that wouldn't have bothered me. I mean, you can walk on a cliff. You're not going to jump over it unless you want to. But this made me really scared, like, oh my God, I can fall. And I guess that's the danger that I see with all these policies, is that we are losing the common sense as a population, and the fact that the more sometimes we try to teach the population that the less they think for themselves, it's a worrying fact. And that goes especially with nutrition and movement.
We're going to just pass that microphone to this lady here, please. So we have the deserving and undeserving poor in this country, according to some politicians. We may also have the deserving and undeserving ill, but we will leave this to you to discuss. Right, what's your...
Hi, good evening. My name is Abby Bejo. So I guess I'm going to ask Louise the obvious question leading on from James's presentation, which is, did you look at ethnicity and socioeconomic groups, and did that vary, did the data vary according to that ethnicity and socioeconomic group?
Thank you. Okay, let's try and do one more up here at the end, because it's going to be faster, then we'll have some answers to the first round of questions. Okay, I'll try and come to you.
Thanks. Hi, Amy Gray from Tesco. I feel I should point out that Lidl caught up with where quite a number of other supermarkets had been already by removing sweets from their checkouts. So you'll only find them in Tesco Express stores, not in all our larger stores. Quick plug. I was really interested in what you said about how when you present other government norms, people are much more likely to accept them, which suggests that the public is extremely risk averse and unwilling to be in the vanguard of public health measures if they haven't already been tried, tested and proven to work, which makes things like minimum unit pricing, which hasn't been tried anywhere in the world in the format which Scotland is trying to do it in, for example. So I think that's quite interesting. And Duncan, I'd be interested to know if Public Health England is keen to be out there in the vanguard of anything in terms of worldwide approaches to public health, but this maybe makes you feel like we need to hold back a little bit at first.
Okay, so let's start with the public health people about whether we're becoming too overprotective. Are we becoming overprotective and just ignoring common sense?
One of my favourite phrases at work is, if we've got an outbreak of common sense, then that's always a good place to be. I think, actually, I don't think we are being overprotective at all, to be honest. You know, if you look at the range of different interventions which could be put into place, but aren't currently being put into place because there's not sufficient public support, then, you know, I think probably we're erring on the side of definitely not being particularly in any state at the moment, which I guess is one of the, you know, that's the how do you achieve that right balance between public acceptability and protection, where you know that something will be an effective intervention to protect a wider range of the public.
James, where are you on this?
Well, I mean, it's a real problem in particular with pandemics, particularly because at the start of any pandemic, you just don't know. You don't know how severe it's going to be. So you always will have to push out advice about you should wash your hands and you should be sneezing into the tissue, which, guys, you should be doing anyway, by the way. So it is a difficulty where we will never know at the start how severe it is, and it's only in retrospect that we can look back and go, well, okay, swine flu was mild. Although even a mild flu outbreak, it still killed over 400 people. So, you know, it depends on your perspective, I guess, which a cop-out answer maybe. But
referring more to lifestyle in general, and the scare message is constantly being bombarded to the population, and the population is expected to be told what's good and what's bad all the time, rather than knowing from family knowledge and personal.
Duncan.
I was sort of reflection about, people don't respond to being frightened. And I think what the evidence is showing is that they're not paying attention unless it has meaning for them. They're not acting on it, which is why we've got these gaps. I was trying to convey that the gaps are more contextual about your income and your living circumstance than it is about any messages from government. There's just other things going on in their lives that are more important to them. And unless we find ways of reaching those that are not hearing the messages. I mean, you meet very few doctors that smoke, for example, but there are some of our communities where upwards of 50% are smoking, and these are choices that, of course, they're exercising. It's not about us saying you shouldn't smoke. It's about widening the opportunities or possibilities that they have to not smoke. And they're more concerned about the children than they are for themselves. So I love this stuff about how you frame it and how you reach people in ways that are meaningful. We had the recent floods, which were, you know, as awful as could be for those affected, and the issues that will flow from those are not microbiology, but they're not about infectious disease, they're about mental health. We gave 100 significant media interviews saying to the public that there weren't infectious diseases floating from, but, you know, wash your hands, you know, don't go swimming in the flood water, you know. But and then the newspapers were publishing headlines saying there's 100 million bugs per pint, and we didn't bother even checking because we knew that. That's why we were saying it would be better if you didn't swim in it, and you should wash your hands. Now but that was incredibly well received, and most of us would think, well, of course, it's obvious. So I think it's a balance, and trust the people. Recognise that they're living lives that they're living, they're real people in real lives, and we need, if we're going to have influence over them, to be relevant to them, and we just have to work out how to if we can be, you know, how do we do that?
Can I just chip in from a research perspective? So the data I showed initially was looking at whether government should get involved, they had a responsibility versus government should not get involved. When you ask a slightly different question, which looks at it's the NHS's responsibility to look after people's health versus it's the responsibility of that individual. This is, I think, the question that you're alluding to, Janet, which is actually there's quite a strong emphasis placed by the general public on it is individuals' responsibility. So it may not be reflected in everyday life that you see, but the data suggests individuals do still hold on to the fact that it's their responsibility.
And Louise, while you've got the mic, what are the subgroups on the only in class in the data?
Yes. In terms of, I'll do a bit of a broad sweep because there was quite a lot of data covered there.
The tables for the data can be put on our website, so you can have it all and have a look yourself. But Louise?
We tend to see, not so much by ethnicity, which may be because the number of individuals that we're looking at is too small to see a big difference there, but you do see a pattern emerging in terms of wealth. So wealth, however you may want to look at it, be it household income or social grade, or even education status, you do tend to see greater support for interventions amongst wealthier individuals. Conversely, not this data set, but another one, when you look at wealth of a nation, it's the converse. So the wealthier nations tend to be less supportive overall, but individuals within it who are more wealthy tend to be more supportive. It does differ according to what you're talking about. So for example, when we looked at the nudge about free fruit and veg in schools, that was supported more so by those in the lower social grade than the upper. So it depends on what you're talking about, but in general that's a theme.
Okay, and in response to Tesco's, how radical is public health in England going to be, Duncan?
Hello. So I would have made the point if I'd remembered that it wasn't just Lidl that took the sweets away this time. And we work with all the major supermarkets, and we get a huge amount of support. We've just completed, we haven't yet published the results, but we did the Smart Swaps campaign in January, because people are more willing to swap than to stop. Does that make? We have our own, but we do a whole lot of market insight about what do people do and why. And swapping in categories, so you're unlikely if you're going to go in to buy a chocolate bar to come out with an apple, but you may choose something within category. So we work with, you can't demonise food, you cannot demonise drink, you cannot demonise employers. We need to work with and through. It's really important to make the point, and there is a huge contribution that our supermarkets have to make. Just on your point on alcohol, there is evidence, about 9 parts of the world that are looking at 8 different forms of minimum unit price, and the point is the evidence is there that price affects consumption, and it's particularly about the very young. So it's not about, and the very, at the real severe end, it's not about your ordinary drinkers. I personally misunderstood 5 a day for years. I thought you were supposed to have 5 drinks a day. I never understood that one properly. So it's not the case that no one's tried this. In particular, the Canadians have done probably more than anyone on this. So we're not making law. We're simply saying that liver cancer is the one cancer that's going in the wrong direction. Alcohol is the 5th leading risk factor affecting length of life and misery when you're alive. It's the one long-term risk, if you like, that's increasing, because although we're concerned about tobacco, we're at least seeing it coming down, not fast enough, but it's going in the right direction. So we're not radical, heretical sort of extremists on this. We just want to see what the evidence is saying. We'd like this one listened to, because we're very sure that it will help with young drinkers.
Okay, thank you. Right, you've been waiting in the middle, so we're just going to pass the microphone to the lady with the red hair in the middle, if we can somehow, down, and then we'll move it along the rows. And a gentleman at the back, another gentleman. Okay, I've seen you. I'll try and remember. Thank you. So if you can get one here. Here it's arrived. Okay.
Thank you.
Who are you and what's your question, please?
Yes, my name's Kat, and I'm a writer from the country that's sadly with only 12% of the public supporting any kind of government intervention. So I'm from New York. Everybody knows just how sad the situation is in the States, and we even call what we eat SAD, stands for Standard American Diet. So my question is about dietary guidelines. And you mentioned today came out like it's now 7 instead of 5. So in the States, a great confusion every time there's some kind of news report. The new studies that come out, all of a sudden, it's not fat. And then coffee once upon a time was bad, and then it's not so bad. And then we also have like a saturated fat, and then things on different kinds of diets. So how quick do you think, I think BBC reported like the government's not going to change the guideline right away on this 7 versus 5. So traditionally, or what's the practice in here, that government responds to the latest scientific findings that may or may not stay or be overturned tomorrow. And maybe if in the end, a little bit advice for my fellow countrymen, which but those of that support, yeah.
All right. Okay.
Thank you.
Could you pass it down there as it's in this row? There's just a lady here. It's two or three on your left, and then we'll take one of those, and then this gentleman at the back, and then I'll come back to the front in a second. Go on. Yeah.
Catherine Drayson from Policy Exchange. Last week, the British Medical Journal published an article claiming that local authorities were plundering public health budgets for non-public health, apparently, services like green space. Green space is my particular interest. So I just wondered what your position on that was, whether you're generally supportive in the right circumstances and what those circumstances would be. But also, you were talking about framing of messages, and given that parks do have public health benefits, I was wondering what framing you would recommend for healthcare professionals to start prescribing parks as a kind of social prescription.
Okay, thank you. And then this gentleman at the back here, we've got a microphone next to you. Thank you.
John Farmer, interested layman. Commonly, 20% of what's done makes 80% of the difference. Would it not, therefore, be sensible to press for banning smoking in public places? Given the strong consensus in favour of this, according to a UCL Centre of Expertise, only 20% of UK adults now reportedly smoke. And a London School of Hygiene and Tropical Medicine annual pump handle lecture recently identified this as the single most useful intervention. Perhaps Louise Park could display again her paradoxical slide of the two circles on attitudes to smoking, but would it not be sensible just to press for a central government initiative and get it done? Because all this waffle and attempts at public information, it seems to me, is falling by the wayside. For example, as an aside, I've had interaction with a Westminster health promotion desk where the key people didn't turn up 3 times running. Now, surely, therefore, we should just get it done, because this lack of ban is shifting the problem sideways, like to the entrance of stations, the entrance of offices, and the benefit to be achieved from a ban is huge.
Okay, so the Vladimir Putin approach to public health, which has some sympathy. So we've got here then something that we've seen continually in public opinion over decades, this confusion over advice that we get from experts and what's in. Is margarine in or out, 5 or 7 portions? When do the experts start to listen to the latest medical advice? Or when do they pause? We've got the plundering of your budgets to spend on things like skate parks and parks, and then we've got the prescription of walking in parks, etc. And then we have, should we just do the things that are the bleeding obvious, like banning smoking entirely? Panel, the floor is yours. Who's going first?
Well, Janet, if you do the plundering one, I'll happily address or seek to address the diet question, and I'll have a go at the gentleman's point at the back. I think I was extensively quoted in this BMJ article in any event.
And I was extensively interviewed, and only a small bit of what I said got in.
So should we believe what we read in the papers, Janet?
I think, what that article was based on was a freedom of information request of all local authorities asking about what had changed in terms of commissioning since move over into local authorities. And to be honest, if you move a function into the local authority because that is a place where you can address the wider determinants of health more effectively, then to actually see a shift in the way that money is being spent is probably a very positive thing. I think there are undoubtedly some challenges within there are major financial challenges within local government currently, and I think it is really important that the ring-fence public health grant is used to get the best public health outcomes, the best value for money. But it will need to change from where it's being currently spent. And I think that there were some really good examples of how local authorities had changed the way that they were commissioning to get those better public health outcomes. So I think there probably, there are undoubtedly some places where there are issues, I would say, but that is not the general picture. The general picture is one of public health getting embedded in local authorities, starting to have a real influence, and things starting to shift. And some of the examples actually that were given were things which actually local authority, that PCTs would have been commissioning for many years, and certainly there was one example about commissioning Citizens Advice Bureau. Well, certainly personally in Sefton we have commissioned that service for probably about 10 years. It's been thoroughly evaluated, has got excellent results, reduces health service usage. That is good use of public money, I think, and that's what I would say is the major message from that. But I also think that it is really important that local authorities do try to protect that money longer term, because it is a real means of getting prevention, early intervention, safeguarded within the system, which is one of the means by which both local authorities and the NHS can become more sustainable long term, is by keeping people healthier for longer.
Thank you.
So keeping people out of hospital wherever possible. The public health grant is 3%. Our interest is in 100%. It's about how it can help influence everything. I've been to many parts of England in the last 12 months, and I am astonished by just how welcome the return of the public's health local government is. I've modified how I speak about this now, because I used to agree when they said it's come home. Now what I'm saying is it never left. The point is, if you want to influence lives in ways that have meaning, then the best place by 3 country miles is to do it from within local government. Not on their own, but they're just connected to the people and to democracy, and they can influence economic prosperity, and they are really going at this. And of course there are always places that you wish were going a bit faster than they are, but that was always the case in whatever system. I think it's a good place for this to be within local government, and I'm really not asking about the 3%. I want to know what they're doing with all of it, if that makes sense. To your point, Kat, I think it was Kat. I think we follow the science as the straight answer, not the headline. And you made a number of observations about, is it okay to have a cup of coffee before 8 o'clock, or is it on a Tuesday before 9? What is it? There are 3 or 4 stories every day. We were on not personally, our chief nutritionist was on Daybreak this morning, about 5 a day, making the point that, as I was earlier, that whether it's 7 a day or 10 a day, people aren't getting it now. So the issues are. And then there's the big debate on sugar. The World Health Organization have just said actually they'd say it's 10%. That's actually where the UK is at the moment, but they've said we want to explore 5%. We want to see what we need more work to see if the health benefits will be there. But as a nation, we're currently at 14%. So wherever this is set, we know we're ahead of where we need to be. And we need to be working with the supermarkets, we need to be working with the schools, we need to be working with families and individuals about how we can bring this down. I think I'd just say very directly to you, we just follow the science. We do not jump. If we're going to be authoritative, we need to understand the science, not just the individual study, but the body corporate of the science, and act on that. Would you like me to talk?
Talk about bans.
To the gentleman at the...
Yeah.
England at the moment, we have the fewest. If you heard me earlier about the gaps, the inequalities or the range here, if you just take the aggregate number, it's the lowest level ever. It's around about the 19% mark. Where I'm more I think I'm personally more motivated is about children not starting to smoke. And at the moment, about 10% of 15-year-olds are picking up on smoking, and I'd like to see us tackle that. So it's more a matter of how we take it out in a generation, rather than say to people that we don't think that you should be smoking, and the answer is a ban. Does that make So my focus is on, it's likely to be on, we're still thinking this through, is to be on the very young, and about finding as many ways as we can to persuade them that taking up smoking is not a cool thing to do.
Okay, and James, in your work, when we're talking about big public health risks, fast moving, are the media helpful or unhelpful?
Well, when the risk actually arrives and it reaches our shores, they're helpful, and they help very much in communicating the message. You look at the swine flu pandemic, and the messages were largely very accurate. There was a paper by the Glasgow MRC unit going swine flu, one health risk not overblown, because they analysed all the data from the newspapers and it was spot on. I think more of an issue is the constant drip feed of scare stories makes us kind of sigh when we see the next one and go, oh, here we go again. And certainly one of the issues we found when we looked at why the public weren't reacting before swine flu cases started to arrive in the UK, or when the numbers were still very low, was because people just thought, yet again, this is one more scare that's been overblown. It's like the Y2K bug or Ebola that was supposed to reach our shores. SARS never made it here. Flesh-eating bacteria in bananas.
Disappointed.
I work in this field. I want these things. You know, where's my disaster? But the drip feed of it does have a negative effect. We are kind of now we habituate to the risk messages, and it does become problematic. So finding a way to get past that and get past that habituation, that's the real challenge for public health communicators in this field.
If I could just jump in there as well on a couple of the points. Talking about the kind of general confusion over time, the guidance seems to change and so on. You'll know better than me, Duncan, about this, but it will be important going forward to what extent the public recognise Public Health England as a body and look to them as the authority to give that definitive guide. So it's still early days, although it's a year to date. There's lots to be done, but that's something that will be of interest going forward, I think. And in terms of the plundering of budgets, again, Janet, you might know better than me, but I think one of the probably a higher concern within local councils is to do with recruitment and posts being filled. So if we've got, is it something like 30 directors of public health posts that are still vacant? I don't know if that's the most accurate or up to date. But it's quite a sizable proportion, and that presents a challenge clearly within local government for things to bed in. So that probably is quite challenging, more so than the plundering of budgets. And also that in a handful of cases, I understand that directors of public health don't always have a direct link up to chief execs in local councils, and that itself can prove difficulty in terms of budgeting and financing.
Okay, right. We're going to do one last round, and then the questions and debate will take place over drinks upstairs and some snacks.
Not
right,
too
one
many.
there and very healthy ones, and one here who's been waiting. And I'm sorry, everybody else will have to come in a bit later. Right, go.
My name's John Smith. I'm very much interested in public health as it relates to young lives. Often, historically, it's almost been public health has been an 18-plus issue, but clearly. With things like nutrition, mental health, physical activity, things start a lot earlier. I'm wondering to what extent the move of public health responsibility to local authorities can be a trigger for us doing much more in the school environment than we're currently doing to date. Thank you.
Okay, and you've been waiting patiently. If you want to come in, can we get a microphone down here, please, at the front? Thanks.
Hi, I'm Cleo. I'm an MSc student at International Public Health at Westminster University. So if we look at compliance rates, clearly behavior change, communication, interventions don't work, or they're not enough on their own. So the only intervention that actually had great results is smoking, and that's because it was a framework that addressed different levels, not just the individual, so not just giving the knowledge, but also as an organizational level and a legal level, so banning and taxes. So my question is, do you think that behavior change communications are enough on their own, or do you think that we should see future interventions as frameworks that address different levels? Thank you.
Right.
Can I, with the framework question? I completely agree. I mean, in psychology, for a long time, we've been stuck in the mindset of an intervention is basically communication. If we communicate better, people will change their behaviour. And you're right, it works to a certain extent, but that certain extent is that, and we want it to be that. There's now a move within health psychology towards looking at the other angles within behaviour change, and we do have to feed those in. So, for example, uptake of flu vaccine among NHS workers. Yes, one aspect is communicating with them about the reasons why you should have it and what the side effects are, what the benefits are. But there are also issues to do with simply how much time do they have to go to the clinic and get it. And if you take the vaccine to them and remove the barriers surrounding, well, I'd have to make an appointment, that's more effective as a strategy. And you're right, the interventions need to go all through the hierarchy. So the managerial responses, the funding level, all of these things play a role. If we focus just on communication, we're missing out on so much more that would influence behaviour. So I think you're absolutely right, and I think we're just at the starting point of working through all those steps and integrating them better.
Just picking up on that issue, I think most of the issues that we're trying to deal with are complex issues, so a single intervention is unlikely to work on its own. And I'm quite taken with the whole thing about large-scale change approaches where you have a common goal that you're aiming for, but then get lots of different stakeholders playing their part in actually delivering a small part of that change. So if you think, for instance, about something like getting the population more physically active, to give people the guidelines that you need to be exercising, however many times, how many is it now? Anyway, however many times you need to be exercising.
150 minutes, John.
More than we do.
5 times 30, is it not? Yeah. So, but if you just give those guidelines, but you haven't got anywhere safe for people to go out and exercise, so they don't feel safe going out for a walk or in their local park, or don't have access to particular leisure facilities, then that's going to be difficult. If transport isn't geared up to actually make building activity into people's daily lives, so that walking and cycling are seen as the preferred option, or using public transport rather than using the car. All those different things can impact on whether or not people do actually succeed in making a sustainable behaviour change. And then just the gentleman back around about early life. I mean, I think schools are important, but actually that period before children get into school, the early years period, is probably the critical time in terms of establishing patterns for life. And certainly my experience of working closely with Director of Children's Services and things like children's centres, particularly targeted in more deprived areas, I think there's much more scope for dealing, for addressing those issues, getting services much more integrated. And certainly in terms of the public health responsibilities of local government around commissioning 5 to 19 public health programmes currently, and 0 to 5 public health programmes from October 2015. I think joining that up with a lot of the things which councils already do has huge potential, and I think that's really something where we need to be looking. The other thing, it was something which actually occurred to me, was before you'd actually said it, was actually about young people's, particularly teenagers' attitudes to some of these lifestyle behaviours, because there's some really interesting things happening about teenagers' lifestyles at the moment. We're looking at sort of teenage pregnancy rates, lowest ever, alcohol, the proportion of teenagers drinking is coming down. There is the ones who are drinking are tending to drink more, but actually there's many who aren't drinking at all. Smoking rates coming down as well. So there's something very interesting happening with this cohort of young people, and whether that'll be sustained going through, it'll be interesting to look at their attitudes.
Yeah, and in terms of the data, so looking at what individuals perceive as the greatest threats to their own health, for the youngest age group we've got of 16 to 24, it's very much stress, diet and exercise. Which is different, obviously, to the older profile. The younger groups are also more likely to mention smoking and mental health. So that's something for wider consideration.
Okay. Duncan, I'll give you the last word.
So we should trust the young. Yeah? It's just us. Well, if I look around the room, some people here will be fine.
Thank you very much. All right, so drinks are upstairs. Thank you very much for coming on behalf of King's and Ipsos MORI's partnership. And thank you so much to the panel. I think that was great. Thank you.